Hello, my name is Hope Frost, and on behalf of SBK Healthcare, delighted to welcome you to this video on enhancing your telephone diabetes consultations. We do hope that you enjoy it. Please share your thoughts in the comments and make sure to like and subscribe so that you don't miss out on any future content that we upload. It is now my pleasure to introduce your webinar chair, who is Theresa Smyth.
Thank you very much, Hope. It's a real pleasure to be here today. I have the privilege of introducing Cathe Gaskell. Cathe Gaskell is a really experienced nurse. She's been a director of nursing, a chief exec, and she now has her own company, Results Company. Cathe has a particular interest and expertise in communication and the words that we use and the impact that has on our rapport with people. That's so relevant to diabetes and today's talk about enhancing our telephone diabetes consultations. From my perspective as a diabetes nurse, I thought that I was all right with telephone consultations, but the last few months has been a real steep learning curve, trying to adapt telephone consultations for people that I would normally have seen face to face, and it's really been quite difficult. So I'm really looking forward to hearing Cath's talk today. So without further ado, Cathe.
Thank you, Theresa. Hi, everyone. I'm back. Lovely to see you all. Well, you can see me, and I'm really looking forward to today's session because phone work I just find really interesting. And if you've been on any of my other sessions, it's going to cross over a little bit, but there's some new stuff I really want to bring in. And I think the reason it's going to be so relevant is we know that telephone consultations are increasing at this time. So let me get you onto the first slide. Okay. So this slide, if you've seen any of my earlier webinars, you know the slide, but the two bits I really want you to concentrate on is it really likely that COVID-related diabetes work is going to increase, but also there's a real government push for telemedicine. And one of the things that's so interesting, and we talked about it last week, is that our patients prefer, if they can't have face-to-face, they like a phone call. Video hasn't grown at the same rate. So you are very likely to be doing a lot more phone consultations. And that's the bit I really wanted to talk to you today and share with you some of the tips I've got about what makes a great phone call, but also there's some really important words I can give you to help your phone calls be more effective. So bear with me on this. Right, so I've got the objectives for the session. And I've put in a word there, telecharisma. That's what I want to build. I want to build your telecharisma so that you have a really good rapport with patients. Going to remind us all about confidentiality, because when we're not in the room and seeing the person, anybody else could be there. So holding that at the back of our mind. Active listening skills, which is so important, trying to build rapport. Now, they're doubly important when you can't see the person's face because you can't judge the expression. You can't see how the words have landed. So active listening skills are key. Consultation skills, but also ongoing learning needs. Probably phone consultation is the thing that I've had to practice the most because it keeps changing and we're learning about it all the time. So I'm going to talk to you about maybe in the future having some scripts, having some commonly raised diabetes issues that you've got answers for a phone consultation. So I'm going to move you on now. So if you've been on my workshops before, you know that I'm really keen on the right environment. So as I said, when we started in March, we just rocketed through this whole remote working stuff and we didn't give it much of a thought. I was working from the kitchen table, wasn't really thinking about the calls I was making or the difficult conversations I was having. And what I really realized is your environment, your work environment is key to you being successful in consulting with patients. So you've got to be comfortable, you've got to be really aware of ambient noise. So on phone consultations, it's really, really important that there isn't other noise in the vicinity. You've got to think about, you've got to sit somewhere possibly for an hour. How comfortable are you going to be? Have you got your notes? Have you got everything ready? We've got to move away from, this is a temporary remote working is a temporary thing. This is going to be a long-term situation. So making the environment as right for you to have a successful phone call is important. Now, sometimes on phone calls we scrimp a bit because we think, oh, the person can't see us, so it doesn't matter if I'm sitting as this person is at the top. It does matter for your back, for your health, and for your ability to concentrate, because in the phone call you are listening for cues that you would normally pick up visually. Okay, so building your telecharisma, that's what I said we were going to be doing. Our tone of voice affects 84% of our ability to concentrate. So just think on that for a second. Our tone of voice, the way we talk. And you will all think back, I'm sorry for GP receptionists, but you'll all think back to the time you rang the GP and you wanted the appointment and you had an abrupt voice, or you had somebody who was curt, or you had somebody who interrupted you. Because you don't have the rapport that we have with eye contact and studying someone's face, you've got about 6 seconds to build rapport when you've got a telephone consultation. It's really speedy, and your tone of voice is key. Now, one of the tips that people who work on the phone all day say is stay hydrated, because actually, if we are a bit dry, we sound tired or we sound bored. And so it's really important. So I've got my glass of water here for the session. Stay hydrated, because your voice is your tool for communicating. Smile when you speak. Now, this is a common one. This is one that I've used from people who are in telesales. If you smile when you speak, you sound more friendly. It's really important to think, right, how am I going to connect with this person? They don't know me, they can't see me. Smile. And slow down. Slow down when we speak. Now, I've referred a few times in the webinars that I've been shielding. And during the time of shielding, I've had lots and lots of calls from different people, health organizations, and I believe they're not interested in me when they speak really quickly. So when they start a conversation, they don't ask me who I am, they start talking to me, and it's so speedy. My instant thought is, you just want to get off the phone, you're not really interested in me, and I end the conversation as quickly as I can. So I end the consult without talking, because I've read through the pace of the conversation, you're not interested in hearing what I've got to say. So paraphrase and check your understanding. That's really important. It's really important. I might be telling my story, and I'm going to talk to you about the optimum time you let the patient talk, but I might be telling my story, but if you haven't paraphrased it and understood it, we haven't got the connection. So that's a really important key. And this is one that you're going to go, oh, I wish we could take a break between calls, because constant calls also dulls your ability to have that rapport. And I'm talking 5-10 minutes, have a comfort break, have a drink, stretch, move around, because you're important. This is your clinical work. This is important work. So make sure that you look after your physical being at the same time as doing consultation on the telephone. It's not easy. It's not easy to speak all day. So we're going to take this as a real skill between calls, have a break, hydrate, right? So tips on rapport, right? Now, this is when you're going to say, what do you mean reduce mouth noises? Patients can hear if we eat. So if you're ever on the phone and you're eating, or you're sucking a sweet lozenge, or you've got something in your mouth, or you're drinking, patients can hear. So it's come across, it's been raised as an issue that people find really irritating or really off-putting if they're talking for a long time. Mouth noises. So think about it. If you're going to have a drink, say, excuse me while I have a drink. Don't eat on the phone, and I have done that, but don't eat on the phone. Just think about the other person at the other end of the phone. What's the impression they're getting when they're giving over difficult information? Repeat the patient name. That's a really important one in building rapport. So if someone I've talked to says, thanks, Cathe, or calls me Cathe, I really appreciate that. It makes me feel like they've made the effort to read my notes. It's a simple tip in building rapport. Use the person's name. Obviously, if it's a complex name, it's a really good thing to say, I don't want to get your name wrong. Could I just check how I say it, please? And again, respectful, but you're building rapport. So try and get that name into the conversation. And this is the key one that I love. Don't be tempted to multitask. So I'm going to introduce you to something now called secret listening. Now, if you're a parent, if there are any parents on this call, you will have already done secret listening. It's when the kids are talking to you and you're really busy and you've got something else on and you do the Except humans, we can hear when you're not really listening. And a tip, if you're secretly listening or secretly pretend listening, the person will tell you the story again. So don't multitask. You can be writing notes or scrolling on your phone or doing something. It comes out in a phone consultation. So time and time again, people will say, I didn't feel heard. When we multitask, we don't focus, and that slight shift of attention, you can hear it in your voice. When someone's saying, and actually they're scrolling or they're doing another piece of paperwork. And we all multitask because we work in health, so we're doing lots of things. It really comes across. So phone consultation, one of the tips I have is I shut my eyes. So if I'm listening, and it's a very intense conversation, I shut my eyes because I can fully hear what the person is telling me. So it's really important. You want to build rapport, you've got some difficult information or a lot of information, close your eyes, hear it, and then you can make notes. But be conscious of multitasking can kill rapport between us. Okay. So active listening, and I've talked about this quite a lot. It's difficult to explain in 10 minutes or so, but active listening is the best skill I think we can have in healthcare. And I wished I'd have known more about it as a nurse, because I've referred before, active listening isn't problem solving. It's actually allowing the person to talk us through what's going on. And it's very difficult for us to learn this because it's so easy to jump in with a question. So I said earlier, I'm going to give you the optimal time to allow someone to talk. The optimal time is around 2 minutes. Psychologists have said that's the time that you sort of have the dump. The person's going to tell you the story. So if you want to build rapport, you need someone's history, or it's a new consultant, you're trying to find out about how the person is coping with the diabetes. It's about a 2-minute window that people need to get things off their chest. And what I normally say is, if someone's on a roll, don't ask a question, just do a paraphrase. So if someone's saying, and then this happened, and that happened, and this happened, that's not a time for a question. It's just for a paraphrase. And at that point I say, can I just check? Is this right? This is how you felt. And that paraphrase is a great way of building rapport, but it also will, it will shrink the time you need. When you throw a lot of questions in, it can actually stretch the time. Let the person have 2 minutes to actually tell their story. So when I'm doing any sort of initial interviews with somebody, you have the open questions, information gathering, and you'll have some specific clinical questions, open questions, get the person to talk. It's okay, we talked about this last week, to tell the person that you have a time limit for the conversation. So it's okay to say we have 15 minutes. It's a boundary to set. It's okay to say that at the beginning of the conversation. And as time's ticking on, you may need to use closed questions, paraphrase, summarize to end the conversation. So as the conversation's coming to an end, you would wind it down with a closed question and just be checking out that what you've taken down is right. We talked about don't interrupt for the 2 minutes, that golden 2 minutes that psychologists say we all need to go to tell the story. Stay focused on what the person's saying. Show empathy. Now, remember, you can't see your face. So how do you show empathy? It's that, that sounds difficult. Thanks for telling me. Few little phrases that you can bring in to keep the conversation going, to extract the information, but build the relationship so that they want to talk to you again. That's really important. You don't want to lose someone because they felt it was an uncomfortable experience. And then don't problem solve too early. And this is the one I talked about. Sometimes someone's only told us a part of the story, so part of the clinical story. and we've come in with a solution. And it's easy to do, but someone's come in, they've told you part of the story, we've interrupted, we said, have you thought about this? Have you done that? And they actually say, oh, well, actually, this is what happened after that. So don't problem solve too early. It's really easy. It's tempting because we are good at giving care and advice. Try and give that person a couple of minutes to get their story out, particularly if they're giving you a history, their story out before you solve the problem. Okay. Right. Information. So I've put a little stuff in there, which you guys will have rocketed through because you've been doing this now for 5 or 6 months. One of the things I keep wanting to mention is safety netting. And I mentioned it last week because it's a really key thing at this time of COVID to put in. And safety netting is what we've told the patient to do or what we've written the patient should do if things don't go as expected, or in most cases, if they clinically deteriorate. It's really important, and we talked about it last week. It's important for your clinical practice that you've documented it. It's important for the patient that they know what to do if they deteriorate. But it's also something that's been audited a lot, and we at times leave out safety netting. We leave out the advice on what to do if things don't go as planned. So I just want to make a plea. It's a really important thing to include in all your notes, particularly at this time of COVID when things are deteriorating, patients can deteriorate, things are moving very rapidly to get that safety netting in. And part of the safety netting might be having a low threshold for a face-to-face. So it could be that people actually need to come in and be seen, because phone consultations are fantastic at being able to reach people who are remote or are shielding or because of the risks to us, but they also don't always paint the full clinical picture. So telephone consultations are useful, but they're not a panacea, because sometimes seeing the person face to face, you as a clinician can read a lot more of their physical state and being. And that's why in a way videos are potentially more safer. But as I said last week, our patients are still slightly reluctant, still have quite a low uptake of video usage. So think about safety netting. Have you included it in every consultation? Right, just putting down that best practice around confidentiality. Mobiles are considered to be safer than landlines, because on a landline, oh, let me just have a quick drink. On a landline, people have been caught out and that they've left a message for someone, and perhaps the person with diabetes didn't want the family to know that they were having treatment, and it's caused concern. So mobiles are considered safer than landlines if you are leaving a message. And if you're leaving a message, you need to keep it suitably vague, because people have said my confidentiality was breached because I took a call, there was a call left, my parents heard it, my partner heard it, and they knew where it was from. So be conscious of that sensitivity people have about people knowing about their health. So landlines are safer, mobiles are safer. Vigilant to your surroundings. Are you somewhere that you could be overheard? Is the patient somewhere that could be overheard? We've all had patients and we believe you've been talking to them and we find they're out at the supermarket or something. It's really useful to know where your patient is, and are they able to take the call, and are they in a confidential environment so that they can share details. And we assume that everybody's like us and would think, oh, I'm having a call from the doctor, I'll be home. They might not be. They might be at a friend's house, they could be in a public place. Just check out everything that you think you know, just check it out. Okay. If you are recording calls, if it's part of your practice to record calls, we need to tell the patient, and also ensure that you're speaking to the right person. So again, this is where videos are slightly safer. If you know your patient, you know who you're talking to. We do have cases where people have had relatives answering the phone or taking the call or taking the consult. So it's really important just to check out that you are talking to the right person. And I know this is ABC, this is easy stuff for you. These are the little things that trip people up that I then read about, have entered in complaints or have entered in people claiming poor treatment. So just be aware this stuff is being fed through when I look at cases where things have gone wrong. So follow everything as best we can, okay? Pitfalls, I've covered some of these. not speaking directly to the patient, which you talked about, insufficient history taking. That is an interesting one. And again, that can be about the tone and the speed. So we may make an assumption, particularly if you're looking at notes from someone else, that the history is up to date and relevant. And on the phone, again, that pace, I've had it with me, where people have rung up and said, oh yes, we know your history, blah, 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 quickly gone through. I haven't had a chance to say that things have deteriorated, improved, I changed my medication. It's been rushed. And if the pace of the person asking me questions is rushed, I shut up. I don't say, oh, actually, I've been quite unwell, or this has happened, or that's happened. So it's really important to think about, to take your history taking, and particularly check if you didn't take the initial history. I'm going to talk a little bit about premature closure of calls, because that's an interesting one that I think I can help you with. I'm going to give you a phrase so that your patient doesn't feel that you've ended the call prematurely. So I think that's really important. If the patient feels you've ended the call prematurely, they're left with a disappointed feeling, with a sense that they didn't get to say everything. And that's so frustrating for a clinician, because you've been trying to elicit information, but actually there's a word we use that might be closing it down. So I'm going to share that with you in a second. And also we talked a little bit last week, assuming a phone call could be faster than a face-to-face. Not always. Same with the video. It's not always, because you may have a little bit of time building the rapport. Remember, the person's not in front of you, so you can't see any symptoms, you can't see weight gain, you can't see their colour, you can't see their breathing. So it may not be faster necessarily. I think there's a real, I think the government is really hoping that we can pack more phone consultations, video consultations in, and clinicians are saying that's not how it's feeling for us. It's feeling like we need to take the same amount of time to carefully assess the clinical history, the current history, how the patient's feeling, because we haven't got them in front of us. So actually, the plan is you've still got to take those same careful steps. And even more so than video, because remember, you can't see the person. Right, this is a linguistic technique that I've been teasing you about and saying, there is a word that we use in telemedicine that shuts the conversation down. So can I ask people in the Q&A box, it's a 3-letter word, what do you think it is? Can I get you to write what you think it might be? What word are we saying in our consultations that might cause patients to end the consultation or to feel the conversation's finished? Can I ask people to put it down in the chat box, please? What do you think it is? What do you think the word is? Anybody? Anybody? But, oh, brilliant, bye. Oh, I like that, Toya. Now, good, good, good. None of them are right. What is that word? It was nice speaking to you. That's a good one, but that's not it. Someone said, anything else? Close, Tariq, very close. What else? So we've got all, by, but. Do you have any questions for me? Any questions? No? What else could it be? It's a word, we all use it. And it wasn't till a linguist told me what we hear when we say it. Close, close, any questions? And I give you one more shot. What do you think this word is that you're using, that your patients are hearing as you want to go? Anybody else can have a stab at it, be brave. Because you've nearly got there. You've nearly got there. Right, okay. So I'm going to share it with you. And some of you have partially said it. So in the English language, this is a word that we hear as no. But it's not no. The word is any, any. So some of you said anymore. So how this study came about is some doctors were looking at the satisfaction of telemedicine in Canada and were trying to work out why the patients were rating it as poor. They didn't feel that their questions were answered. They didn't feel they were listened to. And when the linguists studied, at the end of each session, doctors would say, any more? Anything else? And we hear any as no. Now, if you think about, have you ever been in a meeting? Anyone been in a meeting where somebody says, any other business? And everyone groans, oh, not any other business. Don't ask anything. Any questions? Anything else? The way we say it and the tone any we hear is no. So when you say to a patient, anything else? Any more questions? They're hearing no, nothing more and no more questions. So it's really important, if you want to keep the conversation going, you take any out. And I've given you a couple of things you could say. So what I try and say now to people are there one or two more things we need to talk about? What would a good day look like going forward? Do you think we've covered your concerns? I take any out because I realised from that study, it's shutting people down. And it was a really big piece of work to understand that any means no. And the way it was tested, the linguist walked around the room and she had a plate of cakes. And she said to us in her tone, she said, any more? And nobody could ask for a cake. She kept saying, any more for you, any? And we all felt it. We felt, oh, she's saying no more. We can't ask any, we can't have a cake. Felt greedy. And she said, that is why any, we hear it as no. We hear it as no more, nothing. And it's a really important word. If you don't want to close a conversation, if your patient is speaking a long time, you might have to say, are there any more questions? And what you're really saying is no more questions, please. But be aware, take it out of consultation on the phone in particular and move towards the, are there one or two? And if the patient says no, that's fine, but they will feel better if they were asked, is there one or two more questions? It's a really, really useful tip. Right. Hope you take that away and start using it, right? Points to consider. So we know 2020 is a strange year and everything's changed, but phone consultations have gone up by 48%. But as I said, not all patients can be diagnosed by phone because they can play down symptoms. We find that sometimes with our older patients, younger patients. And the absence of us being able to see them, as I said, the skin tone, the colour, the breathing, the weight, you can see pain in people's face, you can see how they're moving. All of that is how we make up our diagnosis. So you've got to be really strong in your documentation skills, but also be prepared to have a low threshold. If you feel the phone consultation, you're not getting the right information, or you feel the patient is struggling in any way, we've got to have a low threshold for face-to-face. So it is a brilliant thing, phone consultation, but it is not a one-size-fits-all, because depending on your patient, you may be missing out on information. So really important to have it in your head. Am I getting the whole picture? Do I feel confident in the way they're able to express themselves? Am I getting the whole story? And if not, have that low threshold for a face-to-face. Next steps, I think I mentioned, I think it's a really great idea in teams to keep practicing phone consultations because it's such a skill. And we're really only learning now about the impact of our tone, our pace. This is new. We all used to have phone consults and ring people and have conversations, but then sometimes wonder, why didn't that go as well as I thought? This is a new skill we're learning about how we can use our voice, pace, type of words we choose to actually build rapport with patients we can't see. It's a really good idea, and I've encouraged other teams to start to have some scripts. Be careful of script reading because again, it can feel very wooden. But the other thing is to also have some scenarios and practice. Am I speaking too quickly? How does it sound? How does it feel? It's a real skill. It's a real skill. It's a new skill. So think about, is this something you could do in your teams? Practice telephone consultation with each other and get that tone, and that pace, and the ability to listen. Try and crack that down, right? So I put some additional reading and resources in here because I find it such a fascinating topic, trying to build rapport on the phone. And also I'm going to hand over now for some questions. back to Theresa.
Oh, Cathe, that was absolutely excellent. I really, really enjoyed that. It was so good. There's so much I'm going to take away from today, actually. I'm going to close my eyes, stop myself being distracted. I'm going to be doing that 2 minutes, make sure I'm safety netting every time I do a consultation. And I think the last point as well, just practicing within our teams as well, because it's such an important skill. So thank you so much. So I think we've already got some questions, which is fantastic. So please do use the question answers if you've got some questions, or if you just want to make a comment about what you've learned today and what you want to take away today and what you're going to take away, that'd be really helpful too. But one of the first questions we've had is from Lucy, and she says, how do you suggest managing necessary multitasking, e.g. looking at a patient download while they're on call, or referring to your previous notes, their previous notes?
Sometimes I tell the person, so if I'm on a phone call with a member of staff and I need to look at their notes, I say, can I just stop you for a second? I'm just quickly looking through your notes, because that will stop them thinking, why has she paused? Why has she done pretend listening and she's missed a cue? So again, all about honesty. Where I can, I will tell someone, this is what I'm doing. Oh, I'm just going to stop now and have a drink, because they can't see me. So all of that information sharing, patients won't mind. What they pick up on is if we appear to drift off because we're looking at the notes. And that's the point that can be difficult. But I've had appointments with people who said, I'm just going to check your notes. If I know, I'm fine. What I don't like it is a vague, and I think, what's going on?
Yeah, I agree totally. One of the things, we do our phone consultations at the hospital, and we've been very fortunate enough to get 2 screens now, which has really, really helped. So what I tend to do before a telephone consultation is get on one screen their past history, so I can kind of be familiar with that when I'm talking to the patient. And the other screen, if they've got things like the lead review, being able to look at recent downloads and get those results up. But I think you're absolutely right, is as you're talking to a person on the phone, just say, I'm just having a look at your lead review or your DSM, just looking at your blood glucose results, that's okay with you? And and just informing them all the time. That's really important. Thank you. So another question here is, how long do you persevere with a call when the signal is bad without seeming rude?
Oh, probably only about a minute. I give up, because if I miss important information, and also my cues don't come across. So I've had staff ring me very upset, and when you can only hear every third word, I then miss the cue, and so it causes misinformation. So I always say, stop, I think it might be my phone, can I call you back? I don't persevere with it, because very rarely does it get right. And what I don't want to do is give or I don't want to say yes if they've said, this is terrible, I'm being bullied, and I go, oh yeah, okay, that's good. I don't want to say the wrong thing. So I'm always careful. I'd rather say nothing than say the wrong thing, but cancel and say, this phone call quality isn't good enough. So your time is really important to me. Either I'll call you back now, or we'll rebook, because the quality of the call, it's a bit like if the video doesn't work, don't persevere, because you're seeing the wrong picture and the streaming is wrong, lagging is wrong. Technology is great, but it's not as good as having a human in front of you.
No, that's right. And I think sometimes we do tend to rely on ringing mobiles, don't we? Because we know that we're hopefully going to get the person we want to speak to by ringing the mobile, but sometimes signals can be bad. So sometimes it's a matter of saying, the phone line's really bad at the moment. Is there a way I can ring you back on a landline? Or try and rearrange it that way. You're right. I think rather than trying to persevere and then miss important cues or mishear things, it's really important. Another question is here from Stacey. How can we manage patients who struggle on the phone due to poor English, but bad diabetes control doesn't equal a face-to-face? Yeah. Doesn't equal a face-to-face. We don't require a face-to-face consultation.
So this is where video works so much better, because you can have someone in the room translating. So if ever I've got someone who's got poor language, video works better. If they can get used to it, they can do it on a phone. They can have a relative with them translating. but video is far better because you can see the person. And I understand face-to-face, you've got limited resources and it may not justify that, but video is next best thing. It should really be face-to-face, video, phone, and then email. But phone, I know it's the preferred choice for patients, but video is safer, and it leaves it open to have another person in the room helping them. So you can encourage people, let's try video. We could do it on your phone, but let's try video and let's have someone there to help.
Yeah, that's a really good idea. Yeah, really good. Thank you. Okay, so from Jackie is a question, can we leave a message on the landline if the patient hasn't got a mobile?
Yes, you can, but you've got to keep it vague, because people have complained, as I said, because somebody may have said, oh, it's your diabetes nurse, we're a bit concerned about some of your results. It looks as if, things are not quite right. Something like that. People have said, my mother or my husband or someone heard it. You've got to leave minimal clinical information. So people have said, you can say, hello, it's nurse or Dr. So-and-so. Please, can you call me back? But don't leave information about the condition or also any concerns, because that's technically breaching their confidentiality if somebody else plays the message. And that's where I've seen the complaints coming through, because a little bit of information, but perhaps negative information saying we have concerns about what we found or concerns about your latest blood test, that has felt to be a breach of their confidentiality if they're in a shared house. So I think your name, the number to call back is really the most we should be leaving on a public line. Yeah,
no, totally agree. Thank you. Julia Smith has just asked, can we see those links on the last slide again? Are you able to go back a slide?
I can. So they'll all come out for you, but there was a Confidentiality in Health Records toolkit that was really interesting. There was some stuff on Pulse, NMC, RCN, and yeah, there's been some really interesting stuff being published, because again, it's reasonably new, but GPs have been doing it longer than some of us. So that'll come out in your pack. And anything else I think will be relevant for you, I'll put in there. So you've got lots of reading to do as well.
Thank you. A few more questions. Margaret, please, can you just run through safety netting tips again, Cathe?
Oh, okay, should we go back to the slide? Here we go. Okay, so safety netting it's really simple. It's a management plan that can be understood by the patient. It should be agreed with them, but then what happens if things go wrong? So this is particularly important at times of COVID. So you will do this automatically. You probably didn't call it safety netting, but you would say to your patient, so this is the management plan for now, for your diabetes, but if things go wrong, if it deteriorates, if you become unwell, this is what we will do. So the point of having a management plan is everybody knows what's happening. The safety netting is if things go wrong. And again, I'm saying it a lot more in the atmosphere of COVID. Safety netting is really key, because patients, sadly, at times, families have claimed negligence and said, you know what, we didn't know what to do. Mum deteriorated, her breathing went bad. We didn't have an agreed plan. Now, if you remember that people don't hear things when they're stressed, so safety netting, one of the things that best practice is that you ask the patient to say back what you've agreed. So if you've done a management plan, you ask them to repeat it back. You also ask them to tell you, what will you do if your symptoms get worse over the weekend or at night? What will you ask them to say it back? Now, last week, some people said, I even posted out to patients that I've had a consultation with a video. They actually posted out. It's what we've always done, but it's very important at this time when I'm looking at negligence cases. Sadly, people are saying, I wasn't told what to do when Mum deteriorated. She didn't know what to do. I'm therefore suing. So because I'm a risk freak, I always think, right, let's be cautious, make sure everyone's safety nets. And the safety net might be, so I'm an asthmatic, the safety net for me is to go to the hospital. If I'm, if my breathing deteriorates, call an ambulance or go to the hospital. that's clear. I know what to do. It's very clear. And that maybe the family who's living with the person knows what to do. What we can't do now is not have it written down and not have the patient repeat it back, because it's a phone consultation and you want to make sure they've understood. They've understood the management plan and the safety netting plan. So it's what we've always done, but only about 60% of it was recorded. So when people have audited notes, they said only about 60% have safety nets in. Make sure it's in 100%. Make sure it's in 100% of your notes. Thinking ahead, if patients deteriorate, they will know what to do. But also, I'm protecting myself. You know, I'm a clinician. I need to protect myself and make sure it's written down. It's written down, and I recorded it. But I love the idea that somebody had last week of sending a copy, management plan and safety netting, to the patient. So then you're doubly sure, and it's in your notes. It was sent to the patient, so it's in your documented notes, and the patient has a copy as well.
Yeah, that's really good advice. Thank you. Someone's asking here about phone consultations after an hour become monotonous. How do you deal with that?
It's so true. Can I be rude and say keep them shorter? Because if it takes 2 minutes, psychologists say, to get the blurb out, what I'm going to say, what I need to say, we also can, once we listen to that and have got our listening skills on, so not asking any questions, got the point of, particularly if it's a follow-up consultation, how are you going at the moment, listen to that 2 minutes download, pull out, extract the salient points. So, you know, this is going well, this is not going well. Is that right? Have I understood that? How are we going to move it forward? I don't believe as humans we listen longer than about 40 minutes. It's hard to listen longer than 40 minutes. So unless there is an exceptional reason why the consult is going on or you can't extract the information, you want to keep it to a reasonable length of time, because you lose focus and the person loses focus. I mean, can I ask, how long are the average phone consults? I'm thinking, are they 20 minutes? Is that what people are working on?
What we tend to go on, about 20 minutes, yeah.
20 minutes, I think, is a good time to stay focused. I think if it's on an hour, we all lose the will to live. And then remember the little microaggressions I've talked about. Sometimes when someone's talking for an hour, oh, we look at our watch, or we yawn, and then if it's a video, we've lost the consultation because the person's read, she's bored with me. So sometimes I like the fact of saying at the beginning of the conversation, we've got 20 minutes in this consult today to get the best information out we can for you. So set that boundary. Going longer than 20 minutes, unless it's exceptional, it's very difficult to maintain the level of focus that you need for, I would say, longer than 40 minutes. I can't do it. I lose my concentration.
I think that's right. And I think it's a temptation, isn't there? Because they're phone calls, and what I think I was guilty of doing initially was kind of cramming more phone calls than I would have done if I was seeing a patient face to face.
Yeah.
And actually, they take just as long, if not longer.
They do, yeah.
And
yeah,
so
you're documenting it with your safety net, which is going to be longer. So you shouldn't pack them in.
Write up notes or write them a letter afterwards. You need that time, don't you? So I think trying not to do too many phone calls in that hour as well. Thank you. Stacey asks, what is the best way to communicate on the telephone? As a Bluetooth headset, iPhone headphones, or speakerphones?
Gosh, I think whatever works for you. If I'm on a lot of calls, I put a headset on. It's what you're provided with. So a lot of trusts actually send a pack. It's whatever you feel comfortable with. If you're going to do lots of calls, you've got to find something that you're comfortable with, as adaptable and works best for you. I don't have a preferred one. My biggest tip is to try and have a break between the calls. So no matter how good the technology is, you still get worn out, and have that hydration, because I keep hearing if you are a little bit dry, you sound tired, and the patient reads, oh, they're not interested. So I haven't got a specific favorite. Whatever you feel comfortable with that has the least feedback on it for you.
I have to say, from my experience of doing more than 1 or 2 phone calls, it's quite useful having a headset it allows your hands free to type or to wave about and express yourself. And I think I think it's also, I think there's a danger, isn't there, when you're on a phone, people can start talking to you, or think that you can be easy to walk into a room and think, oh, well, you can just hold the phone call. Where with a headset, I kind of think people don't tend to bother me as much. So I think that's quite useful. But I think it is a personal preference as well.
The other tip for a phone call is if it's a very complex phone call and you are having to be in a room, this is sort of pre-COVID, and you're at work, stand up, and the stand up signal in an office usually means it's a very difficult call, so nobody will come near you. So that's one I use from people who are doing emergency or very complex calls. They stand up if the call is difficult, and everybody knows, right, we need to give them space. You know, that's not the person you can ask about the latest shift or show something to. So standing up is often a code in an office that this call is complex and important, and people don't interrupt you with any minor sort of distractions.
Oh, that's a good idea. Thank you. Thanks. Tariq asks, elderly people with hearing difficulty, can someone attend the call for them sitting close? Confidentiality issue.
Really difficult, isn't it? Because I guess you've got to check whether or not they have capacity to agree to it. I think it's probably yes, because you can agree that for a video, but you need to think about capacity issues, but also from a safeguarding point of view. Is there any hint that this is a coercive relationship? So it's something I would probably make a clinical decision about and actually try and work through. Have you looked at safeguarding? Is there any safeguarding risks? Does this person have a safeguarding history with the person who's involved? Is there any other way that you can, the video, at least you can see if there's any coercion going on. So the video is slightly safer because you can see that. But I think if you think the person can give informed consent about having somebody with them, then I think you're fine in terms of confidentiality. If you feel that any cognition issues, it's really difficult to do phone consultation and video if they have cognitive issues, because using the equipment is really difficult. And then again, it's maybe lowering the threshold to have those people in, because people with cognitive difficulties find using equipment extremely difficult and that happens a lot with our diabetic patients. So really weigh up what's the best way to get the best information, and maybe it is a face-to-face in some cases.
I think, yeah, absolutely. I think going forward, what we're trying to do now is for new patients to see them face to face, and then we can kind of assess them to see how appropriate it is to do virtual telephone or video conferences, consultations with them in the future.
If they can use the equipment, because this is an issue, not everybody can use the equipment. Yeah.
Thank you. Rhonda, how do you start your conversation and check if you're speaking to the right person, especially if the patient didn't receive a letter about the telephone call and he is a new patient, especially in paediatrics?
Oh, interesting. Well, I always start the conversation by introducing myself and just checking, have I got the time right? Is it okay to talk? Because I'm assuming that it is, but it's just sort of a preamble. And then I check that I'm speaking to the right person. And I also ask, is there anyone else in the room? Are we speaking confidentially? So I have a little list that I remind myself. So I say it's Cathe. I'm checking that the time is okay to talk. Is it okay for me to call you and talk now? I check, is anyone in the room? And then I check their name. So I sort of go through the 4 tiers of it. But it's also worth at that point saying we've got about 20 minutes or half an hour, because you don't want them rushing away in the middle of it. And then just checking if it is a phone consult, is there anybody else in the room, and are they speaking confidentially? So it's a bit of a checklist. I try and make it sound natural, but I also don't want to be partway through a conversation and the person says, oh, someone else in the room can hear me, or I've got to go in 10 minutes, or so I do my best to. It also helps me slow down. So before I do a phone call, I take 3 big breaths to slow myself down, and I try and speak. So it sounds slow to my ears, but I know on the phone, people are trying to understand. So speaking at a normal pace sounds rushed, because I know when I take a phone call and someone goes, oh, hello, I'm going to speak to Cathe. I'm like, oh, you need to speak slower in the first instance for them to recognize it's you. And also something really important is to explain the purpose of the call. Sometimes we go straight into questions. And I haven't had the purpose of the call explained to me. I don't know, was it a follow-up? Do you need to see me? Is there an issue? It's really helpful to almost call it Janet and John it. It's Kath, am I speaking to? We've got about 20 minutes, is a good time. And then to say, this is the purpose of the call today. It seems quite basic, but on the phone to other people, to them, it's happening really quickly. So it's quite important to get that preamble out. So you've got the right person for the right amount of time, and they know what you're calling about. Because we're in health, we know what we're calling about. People can be completely taken aback. Why? What's happening? So, and also remember COVID. We're on the COVID roller coaster. So people's emotions go ooh, up and down. Anxiety. People aren't always at their logical state. And many of your patients are at increased risk at this time. And that could be playing in their minds. So I give people a bit of a leeway when we start the call that there could be a bit of anxiety in the air. Am I going to be told off? Have I done something wrong? Am I ill? Is something going to happen to me? That few minutes of explaining the purpose of the call, you normally find they just, ooh, they calm down a bit.
Right, thank you. There's a few more questions here, Kath. Simon and Susan here about nursing homes. Can a phone consultation be suitable? Susan's also said, I also have concerns with patients in care homes. I'm aware that cooperatives have not been allowed to visit post-COVID, and many staff working in care homes are not clinically trained.
No, I agree. I guess it's about whether or not person's got capacity. If they're in a care home and they have any sort of diagnosis of dementia, and let's be honest, many people in care homes do, I am really concerned about, from a safeguarding perspective, whether or not they've given informed consent and whether or not they have a capacity to understand the questions. It's really difficult. I agree, I would prefer to have, if it's a nursing home, a registered nurse or somebody with them to check that they understand the information. It's a really complex one. I think I keep going back to, if the person has cognitive impairment, it is incredibly difficult to do a phone consultation, because is the information accurate? Have they really understood what you're asking them? Would it stack up later if we looked at it and we had a consultation with someone who had cognitive impairment, early dementia, and we were asking them questions which they answered incorrectly, and then we made the wrong clinical judgment? Really difficult. I would be wanting to see, where possible, if we could get a registered nurse in the room to check that they were understanding and they had full awareness of what questions they were being asked. Or a relative.
Yeah.
I know you're saying you couldn't have a relative there because we weren't having people in. Whether it could be a Zoom with a relative, a patient, and a clinician. That would be the safest way. Triangulate it with a relative who had an accurate history. So I'm always worried about people populating things with poor history. So if you had a relative or a nurse on Zoom with a patient, that at least you would have a triangulated version of events. You've got your notes, you've got the patient's version, and you've got the relative's version. I feel you would have a safer ability to make a clinical judgment.
Yeah, definitely. That would be the safest. I think you're right. Thank you. Very useful tips offered. Are there cues you can pick up from patients on the telephone and they are not necessarily expressing explicitly, i.e. worried, scared, agitated, and a simple question to ask to try and tease out the concern?
Yeah. It's difficult if you haven't spoken to the patient before. So I love the idea of always having that face-to-face first of all. So you've seen a standard of how they are. I look out for things like rapid breathing, long pauses. Sometimes a long pause is because someone's crying. So that's also something to pick up on if someone starts crying on the phone. And that silence is sometimes somebody's holding back the tears. And I usually say, what's the feeling behind the tears? And people will say, I'm scared, or I'm anxious, I'm angry, I'm worried. I don't say, why are you crying? Because that makes people feel a bit defensive. So I say, what's the feeling behind the tears? And also allow people to cry. So lots of cues. One of the biggest cues and the best cues is, that sounds really difficult. because you're not actually judging whether it's right or not. So often if I'm dealing with a complainant, I'll say to them, that sounds really difficult. Now, in reality, I don't know if that happened. I don't know, but it's a saying that's neutral, but it makes people feel that I have understood. So by saying, that sounds really difficult, that's quite a good one at opening the door. Yeah, aha. Oh, thanks for sharing that. Thanks for letting me know. The things to avoid are what I call distracting questions and answers. When someone tells you something difficult and we say, am I the first person you've told? Did you not tell the sister in the war? Those ones, we think they mean well, but actually it's almost like pointing the person off to a different direction. Yeah. So I'm really careful about not saying something that might sound like this is not my problem. And a common one is, am I the first person you've told? There's a way of wording that. That sounds really difficult. Have you talked about this before? It's better than, am I the first person you've told? So just thinking about language and how it lands and actually being tentative. So rather than saying, oh, you've had a really awful time, that sounds terrible, I would say more tentatively, that sounds really difficult. And let them tell you the story, because otherwise, if we're not tentative, we could put words in the mouth of the patient. So I'm careful to try and hear their story and not my story. I might be fuming, but I try not to give it away. I try and go, okay, I'd like to hear more about that.
Thank you, some useful tips there, thank you. Jackie here, have patient or relative ever tried to record consultation without practitioner's permission? How do we...
Loads of times, hundreds of times, every day. Yes, 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 yes. So what I have to do is assume I'm always being recorded and I'm always being videoed. It happens all the time and you won't know about it. So I'm afraid my advice is assume that you're being recorded. Now, the tip I will give you is assume you're being recorded, and how would you feel if what you said was shown on Newsnight or Panorama or whatever, which is a lot of cases I've dealt with. But this is the thing you must be very careful of. If you are seeing sometimes a relative or a patient in the room and they may leave the room and their bag is in the room, quite often people have said inappropriate things, not in front of the patient, but the patient's left the room, the family's left the room, the bag has been left in the room with the mobile phone that's recording. And the nurse or doctor or receptionist has said unwisely, oh, what a pain, oh, that will be picked up. So whatever you say in a room, even if the patient is left, assume it could be recorded. So keep any frustrated thoughts to after a consultation, and it'll save you a lot of pain, because people have let out a human response of frustration, but there's been a bag of a relative or resident or family member in the room and the phone was on and recording. So always assume we're being recorded. We have very little choice about it now because people have mobiles that they secrete all over the place. It's not advisable. I tell relatives all the time, don't record us. If you record us, it's already showing there's no trust. It's a breach of trust if you record us. What you must do if you feel you need to record us is ask us at the front of the session. And we will offer a record, and there's one version for us and one version for you. So it's taped, but none of the tapes have been altered or shortened or paraphrased. But it's a fact of life. Always assume you're being videoed or taped, and just be conscious of it at all times.
Well, thank you. Just as a guide, what percentage of time is good for the patient to be speaking during the call?
It depends on the quality of information. I think you can let them have the 2-minute download of, isn't it awful, ain't it bad, but after that, you are not a counsellor. You are there to get clinical information out. So at that point, it becomes your interview. And you ask the questions and you get the answers. Because if it is counselling they need, there are other people that can resolve that. That 2-minute download of ain't it bad is probably the most that they get to hold the whole conversation. Then it goes back to clinical hands of actually taking factual information down that will help manage their their diabetes. Just having a long old rant, it might be fun for me, but it's not actually going to keep me safe in terms of using up the diabetic specialist time.
Thank you. Thanks. So this person, another question here is, I missed the first part and you may have already done it, but how long should the call be? The morning, it took my mother's GP 3 calls to connect a video call, and the whole consultation took about 45 minutes for an existing complaint. It's a difficult one, isn't it? I think we've had responses. I mean, we try and allow about 20 minutes to half an hour per phone consultation, but allow enough time, I would say.
It's how long is a piece of string, because ideally 20 minutes is in the perfect world. You get the right information, you have the 2-minute download, then you ask your questions, then you get your safety net, your management plan, but life isn't like that. I think 45 minutes would be an exceptionally long time to have a call, but if there were video breaks, that might explain it. This is all new world, new technology, and I think we have to have a bit of forgiveness in our pocket, because we're all grappling with this. We're all trying this new stuff. So if it does take a bit longer, we have to have that forgiving heart that technology is what it is. It will break down at times and not work as well, but the intention behind it is good. It's to be helpful and to get the right information to keep each other safe. So you have to have a bit of forgiveness in your pocket, I think, at the moment.
That's been amazing. Thank you so much, Cathe. Thank you.
Thank you both. That was really, really insightful and thoroughly enjoyed by everyone by the looks of it. I'm really pleased that we got to answer all of those questions. And thank you all for attending, and we do hope that you enjoyed it. I'd like to thank Abbott again for kindly sponsoring the webinar. Thank you, Theresa, and thank you, Cathe.
Thank you.